Hi everyone, thank you for watching today's talk on managing the increasing demand for induction of labour, looking at how Dial-A-Pan S has been used as a primary induction agent in a large Essex maternity unit. Our speaker is consultant obstetrician Dr. Shaneza Otigba from Queen's Hospital in Romford, who'll be looking at the causes and solutions for increased IOL demand, the role that Dial-A-Pan S has played in enabling these solutions, and what she anticipates the future of induction should look like.
So my name is Dr. Otigba. This is something I'm very passionate about. I'm a consultant obstetrician and gynecologist. My main interest is obstetrics and high-risk obstetrics, and I'm the fetal medicine lead for quite a large maternity unit in Essex, and I've been a consultant here for the last 23 years. So I've been around through a lot of inducing procedures in my time. But I must say that the Dial-A-Pan that we've been using recently in the last 3 years has actually changed our practice quite a lot. So without any further ado, I'm going to talk to you about how we got to using Dial-A-Pan and how our outcomes have been. I haven't put any data slides in because I wasn't told to, but I can tell you verbally our outcomes if you need to know. So why this interest in induction of labour? What has catapulted induction of labour into the stratosphere, so to speak? Well, it's been a lot of things. I mean, those of us who work in hospitals in the United Kingdom will know that various interventions since 2015 has increased the amount of surveillance we're doing with babies to prevent stillbirth. So in 2015, Mr. Hunt, the then Health Secretary, now the Chancellor of the Exeter, said to us that he wanted to reduce stillbirth by 50%. And as a result of that, a lot of interventions came in. We had to screen for small babies because we know small babies are more likely to die. We had to make sure if mum said they had reduced fetal movements, we acted on them. And we were supposed to make sure we were screening for diabetes, hypertension, and inducing appropriately. There were also other issues that never used to come to the fore. So once you got to the age of 40, you magically became a very high-risk woman and more likely to have a stillbirth. If you had IVF, they were considered you would high risk for stillbirth. So quite a whole bunch of things came along and made us increase the number of stillbirth inductions we had to do. And then, of course, every single hospital in the land will know that you have the HCIB, which is a setup where groups of midwives and doctors assess cases with bad outcomes and implement changes. We know we have NICE, we know we have CQC. So all these external drivers, as well as the internal drivers, has almost certainly increased most people's inductions rates from a 20% that we used to have probably in the early 20s to at least 35 to 40% and probably rising now. However, it has not come with any change in the number of midwives, any change in the number of beds or labour capacity. It has not changed how we manage them. We are now finding more and more midwives are no longer becoming midwives or leaving early, mainly because of all the things that have happened, the pandemic, retirement, exhaustion, litigation. We know that if we induce early, the induction of labour process is going to be longer. So we have far more women who are being induced early because of all the things I've mentioned previously, and having long induction of labour processes. And of course, you have on the flip side of the coin, women who should not be induced, being induced and persisting with them and having poor outcomes. So these two things by themselves have almost doubled the induction rate within our units. So it is not a one-man thing. Nothing happens without a team, and you really need to work as a group. So when we were confronted with the pandemic, and I would say we've been tinkering around with induction for a while, but when we were confronted with the pandemic, we knew we had to maintain an element of an induction labour service to reduce the number of stillbirths, but we couldn't bring them in. But at around the same time, we were looking at safe methods for induction of labour, and of course, the first thing that came to mind was Dial-A-Pan. So we started using Dial-A-Pan in January of 2020, which was before we even knew we had a pandemic. And by March of 2020, we were all in there using Dial-A-Pan. We'd established an inpatient and midwifery-led clinic. Women were coming in, having their Dial-A-Pan and disappearing and coming back again up to 24 hours later. So in a way, it's not a nice thing to say, the pandemic pushed us into doing some things that would have almost certainly taken a very long time to do. And because of that, we were able to then set up a kind of system where we knew how many we could accommodate safely. And you can see on this slide, we would have 2 for labor ward, 4 as outpatients, 2 as inpatients. And of course, with the PPROMs, they were unpredictable. And we still stick to this numbers, even though we deliver 7,500 women a year. Our outpatient of induction of labour has greatly improved with the use of Dial-A-PAM, but I'll go into this a bit more further on. So, of course, there's lots of things you can do before you get to the induction of labour stage, and we absolutely make sure that we use up all the number of sweeps. We make sure women can be induced as outpatients. We RAG rate them backwards and forwards to see whether they can be outpatients or not, and if not, why not? So that we are trying to optimize whatever little space we have on the antenatal ward and make sure as much can be done in the community. So one, it's good for the mothers, but certainly it's good for us as well, because that 12 to 15 hours that they would be hanging around waiting for the Dial-A-PAM to be removed or rupturing membranes can be done at home. So next slide. So I talked about a little bit about outpatient induction, and I will expand on this a bit as well. Now, I think for most units in the country, an outpatient induction is usually reserved for women who are postdates. And as you and I all know, we're increasingly not seeing that many postdates because for one reason or another, they're all being induced before they get to the 40 plus 10 mark. So because we recognize that Dial-A-PAM does not cause any very little, if any, hyperstimulation, is quite comfortable for the mums, we expanded our outpatient induction criteria to not just the postdates, but these are the ones where we would quite happily offer outpatient induction of labour. And as you can see, we look at maternal request, GDM, controlled with metformin with a normal growth velocity, maternal age, the dreaded maternal age, IVF, ISPD, large babies, small babies, but not so small babies, and generally things where we know they're being induced, but actually the baby is not at risk. And by doing that, we've expanded the number of induction of labours in outpatients from 2% to about 35, sometimes as high as 40%. Now, if you introduce all these criteria, you will find that 15% of your babies, that inductions which you would normally induce in the hospital, will be induced as outpatients. So it has actually improved our capacity quite a lot. And it's probably one of the things where Dial-A-PAM comes to its greatest use, because we know that these women, when they go home, they will be absolutely fine. They're only home for 12 hours. They come back. The Dial-A-PAM is removed, and if they are suitable for ARM, then that's where the problem starts, but we'll talk about this later on. So I talked a little bit about RAG rating, and I think it's really important that we have some form of rating for induction of labor too. And the reason for this is we know not every woman needs to be induced immediately, and we know some actually do. What happens if it's a first come, first served basis is you have a lot of women who do not need to be induced immediately being induced and having priorities. And then the ones where we've just discovered this baby is small, or we've just discovered she's got mild severe hypertension, then gets left behind. And so what we decided we would do is that we would have an amber rating, very simple, used in most places. And with the green category, these are the ones that will be told, look, we're giving you this date, but it may change, and it will be a variation of 3 days. The level 2 will be a variation of 2 days. And absolutely, if you're classed as a level 1 or a red rating, you will be induced on the day or within 24 hours of decision making. And by doing that, you're able to make sure the right inductions are done at the right time. And those that can wait will wait, but not for too long. And most mums, if they are told from the get-go that this might happen, are quite accepting of this, because everybody understands if a woman is very unwell or her baby is unwell, needs to be given priority. And by warning them at the beginning, and by making sure they understand why this is, and making sure the staff know that this happens, we manage to stunt the peaks and troughs that you get with inductions. On a Monday, they're all in at the same time, and on Tuesday, there's nothing. And it seems to have worked really well for us. We very rarely have to cancel inductions these days. So how did we do it? Well, I tell you, it was a labor of love and sweat and tears, but we centralized oral inductions. We had strict rules on timing of indication for induction or mode of induction. We made sure that if we had to defer or cancel inductions, there was a way to safety net them by providing CTGs, ultrasound, blood tests, BP checks, whatever is necessary to make sure that when this woman who's been deferred is going home, you have absolute certainty that this is the right thing to be doing. And many occasions we've brought them in to check them and found, well, actually, no, we can't defer this one. This woman has got high blood pressure, or her baby's umbilical artery Dopplers don't look as good as they did a week ago. So it's not just about saying, oh, she's 40 plus 4, we'll let her go and bring her back in 2 days' time. It's about bringing her in, making sure she's absolutely safe before we can say, yeah, this is fine. And in some instances, they come in and say, well, actually, doctor, I don't want to be induced. And say, well, that's fine. We'll have a look at the baby, make sure everything's fine. And then we can have a discussion as to when she would like to be induced. So there are many benefits of having a centralized area where these conversations can be held. Right. Now, I seem to have... Okay, next slide. Just bear with me. So we reorganized our inductions, we centralized them, we color-coded them, we have created a clinic for them, and we've actually appointed 2 dedicated induction of labor midwives and trained all the antenatal midwives. And this is mainly with Dial-A-Pam in mind as the primary inducing agent. I must make it very clear to you now, we do not use Dial-A-Pam for PPROMs. We've never done that. I think this is a version of putting something into the vagina for a long time when we know the waters are broken. I know that it's probably safe, but to be honest with you, you have to pick your battles. And I just felt I'm not going down that road because I just couldn't be doing with it. I wanted to introduce Dial-A-Pam and make sure it worked safely. And the last thing I wanted is a chorioamnionitis, probably nothing to do with Dial-A-Pam, kiboshing the whole project. So that's why we never went down that way. Anyway, back to the conversation. So we trained up the induction of labor midwives. They know the criteria. They have competencies they have to go through. They have to be signed up for at least 5 insertions before they're allowed to work independently, and they get updates regularly. So it is a trained, in order to get these induction of labor board, when midwives to do these procedures, they have to be trained and found competent. And I do have the competencies that we used if anybody is interested in having them. And so once they were trained and they knew how to do them, we sort of let them loose in the induction of labor clinic. But they always had a senior clinician review. So if they had to change anything or move anyone around within reason, I mean, I'm talking about we have no beds, I need to move this term plus 10 to term plus 11, they will almost certainly have to have a discussion with a clinician. But as time went on, they became more experienced, but they still have to have, because it's a point of care issue, they must be seen to be referring the ones where there's potential controversy to somebody who can make a clear decision. And this senior clinician has to be quite pragmatic, has to be able to say, nope, this is fine, this is not. And often with our colleagues, as you know, we're all very risk averse at the moment. It can be quite challenging for them. And that's why we have strict criteria and guidelines that will allow them to make these decisions, which is shared between the consultants and the midwives. So nobody goes, oh, I'm sorry, I'm too scared to do this. Well, it is a guideline. It is allowed in the guidelines, so you're protected by that. So this is the entry to my day unit. As you can see, it's a bit dark in there. I don't know why, but anyway. But you can see how we tagged our little induction of labor clinic right beneath the obstetric day unit. And it has a lot of advantages. The advantages is it is in an area where women are being monitored continuously all the time. So you can almost have a hybrid of midwives who do both the inductions and who do the OAU monitoring as well. Now, obviously, if you're going to be doing inductions, you're not going to be expected to be taking blood pressures and monitoring for reduced fetal movements. But you can say when you've got a whole trained cohort of staff, they can sort of dip in and dip out as is needed. So you don't have just the 2. You have actually 5 women midwives who are trained to put in the Dial-A-Pam. And if one of the senior ones are off sick, we know that within our OAU, our day unit, there are midwives that can slip in and do that. And so we do provide a 24 not a 7-day service, not a 24-hour service, a 7-day service. So that we are inducing from Monday to Sunday every week during the day, and out of hours, that's when the antenatal midwives come in, and they're all trained to insert Dial-A-Pam out of hours. So we have the same setup within a bay in our antenatal ward where they can put in Dial-A-Pam out of hours, and we have a similar the setup in the day unit during the day. During the day, women who are being admitted as inpatients will have their Dial-A-Pam in the clinic because of the activity on the antenatal ward, but out of hours, it's done in the antenatal ward. So this is it. It really isn't much. It's almost like a little cubicle on the side of your day unit. See how they squeeze us in? But you can see here you have a space, and that's what I call it. We'd love to have a room with a door on it, but we don't. We have curtains. I know it sounds awful, but it works for now. We have a CTG machine. We also have a computerized CTG machine, which we use before we put in the Dial-A-Pam, because we know we can use it if they're not induced. Once they become induced or they have contractions, we can't use the computerized CTG. The computerized CTG is helpful because then the midwives don't have to say, is this a normal or not? Is it not normal? It's either the criteria are met or they're not. And for them, if it's met, they're covered. And that's been quite helpful for them when they're trying to monitor women, especially after the insertion. You can't see the trolley of equipment here. And of course, it looks very dark, but there's usually a very good light source. There's a trolley in the corner. Moving on. So if you're like us and you have all these avenues for which induction can come into your unit, there is absolutely no way you can actually coordinate them without having a centralized way of booking. So they'll come from the community, they'll come from triage, absolutely coming from the antenatal clinic. You'll have the odd one coming from the antenatal ward, and every so often they just turn up from somewhere else. They've not been booked or they've just turned up. So you have to have some way of coordinating this. And, if anyone thinks that they can do induction without having a formal care pathway, without having a way it can be managed almost as an elective service independently, it's going to be very challenging for units to be able to organize them properly. So the midwife in the induction of labour suite will book the induction. She will book the inductions in. They get a phone call through a shared drive. She will stratify according to the guideline, first by inpatient, outpatient, and then by risk RAG rating. If there are any wellbeing checks that need to be done, she will do them, especially if they're being deferred. We offer sweeps as well, because sometimes the antenatal clinic is so busy the doctors can't do them. They organize a sweep in a week and then induction week after. We always warn the women, especially the ones that categorized as green, that there may be a delay, so they understand that. But if they are changed, their inductions are not changed again. And of course, in the beginning, we used to have lots of difficult conversations and husbands wanting to throw you out of the building and stuff like that. But that's all changed now because they understand from the get-go, you may not be induced on that day, and they sort of take it very well. So we're no longer having these awful, difficult conversations on a Friday afternoon as to why my wife cannot be induced ASAP, as I was promised 2 weeks ago. Just briefly about the obstetrician's role. I mean, we know what we need to do. If we're given the tools, we'll do it. I think by centralizing a service, it makes it so much easier. Most units will have a so-called antenatal or hot week consultant, and this is primarily their role, making sure that the unit is running safely and smoothly. I've already gone into a lot of detail about what the induction of labour midwives do. The insertion of the Dial-A-Pam is actually the tip of the iceberg compared to all the other activities they do. More importantly, they do maintain an audit of outcomes. And so every month or so, I can tell you how many LGA inductions I've had, how many second round Dial-A-Pams we've had to have. So it does allow you to make sure you have an eye on what you're doing and what your outcomes are. And of course, the community, really important for the post-term babies, women, they need to be assessed and be swept. And often 50% of cases, they'll go into labour by themselves. And if they don't, once they had the Dial-A-Pam and go home, they actually bypass the antenatal ward completely because they come in labour and go straight to the labour ward. So a pictorial review of how our process is. the woman is asked to come in. She's packed her bag. She comes to the day unit. Then the midwife says, "Oh yes, we knew you were coming. We'll put the dial-a-pam in." She has it inserted. She has a CTG. If she's an inpatient, she then goes to the ward. And if she's an outpatient, she goes home with instructions as to when to come in and which phone number to have to ring if she has any concerns. Obviously, these women always have a way to contact if necessary. They don't just go home without any information. So, finally, what is the future for induction of labor? Well, it's just going to go up. And if it doesn't go up, it means the section rate will go up as well. Ockenden has been very good or very bad to us, because my section rate, maternal request cesarean section rate has gone up by 9% since the first report. And no doubt by the time they're finished with all the other hospitals, it'll be about 60%. Women are actually wanting not to be induced anymore. That's how bad it is. But, we're still going through the process. We know that induction of labor is an activity that needs to be organized with a specific care pathway. And absolutely, the women need to be involved in their decision making. They need to understand an induction doesn't mean you're going to go home with your baby tomorrow. An induction may involve a long period of time. If you think you can wait, if you think we feel you can wait, it will be much better for you and the baby, because there's nothing worse than when we're saying, "Well, nobody told me this." Or on the flip side, a woman is told you need to be induced, and she says, "No, I don't want to." "You need to be induced." "No, I don't want to." And then she turns up with a stillbirth, and nobody tells her, "Oh, nobody told me my baby could die if I waited." So, there has to be a lot of understanding between the caregiver and the woman about why this process is being done, and how we can facilitate a compromise with what she wants and what we can offer. So let's go to dial-a-pam now. Dial-a-pam has been a game changer for us. I would say that it's because it is probably the only agent that is used for outpatient induction. And whether we like it or not, we can never create enough beds. We can never create enough midwives. We have to make use as best we can with the facility of allowing women to go back home to their homes. Multiple benefits. One of the biggest benefit is the mother is in an environment where she feels comfortable and safe. So all her sympathetic hormones are not going all over the place when she comes into a strange place in a room full of women who are not very comfortable, spending nights waiting for her to go into labor. So those that can, benefit from an outpatient induction should be offered an outpatient induction. We know its safety profile, and we've used it for 3 years. I can't remember ever having a hyperstimulation that we needed to section using dial-a-pam. It is that safe. And for that reason, women don't have to be monitored continuously. They don't have to have multiple examinations like previously. They request less pain relief. They remain out of hospital. So I think, if we are looking for the future, unless something else better comes onto the market, this is probably one of the better agents to use, given the current climate we have of the increasing induction rate. Thank you.
So that is everything from us. Has anybody got any questions? Lauren, have you got a question?
Hi there. Yeah, so my name's Lauren. I work in Cardiff and Vale. I think Shanez, Sue, who's our consultant obstetrician.
Yes.
So we have expanded our outpatient criteria, but we find that the uptake from women still isn't very good. So I didn't know if you'd done anything to kind of encourage women with outpatient, if it was, was there like a social media drive? Was there anything that you did to kind of...
I think the biggest thing that we said, we emphasized on how nice it would be for you to be able to go home.
Yeah. Okay.
The women in our area are very keen to go home. They don't want to be in hospital. And as I explained to you, because we started this business during the pandemic, nobody wanted to be in hospital. So it was almost like we used that scenario where nobody wanted to be in hospital as as a routine thing. So we said, we have to the dial-a-pam and say, you don't need to be in hospital. We don't want you to be in hospital. You need to go home. So we didn't really use anything in terms of social media. But I think if you emphasize how important it is that, we've assessed you, your baby's absolutely fine. We'd much prefer you to be at home because it's best for you and your baby, and you will be coming in at this time. Most women don't have a problem. I don't know. I think what they may feel...
Sorry,
Yeah.
is it more of a is it kind of like outpatient is kind of the routine and then you opt out of it rather than opt in? Do you see what I mean? Is it more like the routine practice? If you're being induced for this reason, you'll be outpatient.
We would always say, is she suitable for an outpatient induction?
Yeah.
As opposed to, let's induce her. It's the first question we ask. Is she suitable? Has she got any risk factors? No, yes, she's suitable, and we go straight for outpatient. It's our first choice.
Yeah.
But, the majority of our women, 60% will still need to be induced as an inpatient, mainly for fetal reasons, or because there are other things. But in reality, we at one point during the pandemic, 60% of our women were being induced as outpatients. Wow. Then we went down to 40. And the other thing is the clinicians, are they offering it? Yeah. Because if your clinicians don't offer it from the get-go, if you start saying, would you like to go home? They'll think, well, my doctor never suggested that. So, so I think one of the things we definitely did at Queen's was make sure all our consultant colleagues were on board with these women. If there's nothing else, can go home. If you have any concerns, please speak to me. And once the clinicians start saying you can, and the community midwives started saying this as well. So it's not just one person. If the whole hospital is behind this, it does make a big difference, because the mother's getting a consistent advice, and you start talking about it from when they are talking about induction as part of their birth plan. So they'll be told at their birth plan, if you are low risk, as you are, you will be allowed to go home. And that's where the thought starts changing. You can't start offering it to them once the doctor said, yes, you need to be induced. Do you know what I mean?
Yeah.
So I think if you are going to do any drive, I mean, it's good for them to be on social media, but if you are going to do anything, you need to be talking to your community midwives, your doctors, and telling them this is safe. The women are only going to be out for 12 hours, because after 12 hours, they'll come in and have it removed anyway. And as long as everything is fine, you safety netted them properly in the beginning, they are fine. We have not had a problem with the outpatient inductions since we've implemented this sort of management.
Great. Thanks, Shanez, and thank you for the presentation. It's been really informative.
Oh, thank you.
Lauren, just to jump on the back of that very quickly, if you do need us to do any training with your community midwives to sort of talk about how it can be used for outpatients, please do let us know, because we have been doing that in other areas, just so that the community midwives feel more confident to talk about it to the patient. So if you do want that from us, just let us know. Okay.
I mean, lovely. I think they are key, because those are the ones that are the most suitable for induction of labour as outpatients. So I would target your community midwives absolutely first, but make sure the doctors are on board.
Perfect. Thank you both.
Hayley, I think you had a question in the chat and you've got your hand up. Is it for the same question?
It is, yeah. It's just we've got a real difficulty with getting ARMs across at the moment. We currently use ProPES. We don't offer any other method. I've just been put into role as the induction lead to sort of look at it and look what options we've got. I know Dilapan is top of the list at the moment. But do we have a time limit where we need to get them to labour suites? Do things change? I think there's a bit of a rumour mill going that obviously your cervix changes and then you won't be able to you almost have to start again, if you like. And then my other question was, what's the are people labouring off it? ProPES, it's very hit and miss. Some people labour really well and some people do nothing. Is it very similar? Are women labouring?
Beth, do you want to take the first bit?
Yes, I'll take the first bit, that's fine. So in terms of your question, answer no. So there isn't sort of a time limit of when you can ARM them. Obviously, the ideal time would be as soon as possible, but we know that it's a national issue that there's ARM waiting times at the minute. We've got some hospitals up to sort of 5-6 days waiting for ARM. It is really that long. But we've also got lots of audit data that shows that their patients will remain ARMable during that time. Obviously, we don't want to encourage sort of leaving the Dilapan patients while the ProPES patients get to make it to the top of the list or anything like that. Absolutely, they should still be ARM'd at the earliest opportunity. But no, you should be quite confident that they're cervixes will remain ARMable, and we have had audit data to show that, which we can share with you if you're interested to see it. So yeah, please try not to worry too much about those ARM waiting lists. We know that it is a problem, and we are here to support you with that as well. And hopefully if you do introduce Dilapan, you might find that those waiting lists start to reduce. Fingers crossed, that's the aim. But yeah, we can support you with that, but please try not to worry about that time.
Okay, I'm afraid I'm going to have to put a damper on that one, Beth.
Oh no.
So we had huge problems with ARM waiting lists. Huge, massive. I mean, it almost changed. The beauty of Dilapan is actually one of its disadvantages, because your women are so comfortable. Their cervixes are nicely dilated 3 centimeters. They're not in labor. They're not contracting. Their babies are happy. So therefore, there is no impetus. There's no, often if a woman is in pain with Propess, she will make very sure that she needs to go, and you will do everything in your power to do so. But with the Dilapan ladies, they just sit around. And whilst it may be okay for them to wait a day or two, but remember, you've got about 6 or 7 coming behind them. So you really need to be doing something. So we toyed with a number of things. One of the things we did was we created an induction of labor bay. And I must tell you, my midwifery colleagues hated it. So that was one of the reasons why they managed to get them across quickly as well, because they didn't want to do ARMs on the antenatal ward. And they do, in some units, they do ARMs on the antenatal ward. And if I could get them to do at least 1 or 2 ARMs on the antenatal ward and get them to mobilize on the antenatal ward, then we would like to think that if Labour Ward can then just take them just to start the oxytocin, even put the drip in just in case they need it, that will be one of the ways you can manage the ARM delays. But in reality, it isn't that easy. And so unless you have some way of saying, we will have a dedicated midwife on the Labour Ward to take a woman at each shift for an ARM and start off the process while the other midwife who's doing paperwork for some other delivery finishes that and then just takes over. You would really need to have some kind of management pathway that involves just managing low-risk Dilapan ladies who need to go to Labour Ward. And then, of course, the other alternative is to use a second agent, or which could be a repeat Dilapan, which is completely unnecessary if you're 3 centimeters, or Prostin or Propess or oral misoprostol, which is what we use at the moment if we have these big delays. But my feeling is that if you have a facility where you can ARM them and mobilize them one after the other, maybe 1 or 2 hours apart, you can almost say, look, she's had an ARM 2 hours ago, she's ready for oxytocin. Can she be the next one in room 7 when midwife A finishes with that patient? But it has to be a close working relationship between the antenatal ward and the Labour Ward, and often you'll find that's very difficult to manage. So yes, that is one of the disadvantages of Dilapan. It works so well that the women just can flop around forever.
Thank you very much.
Okay.
Gitty, I believe you've got a question.
Yeah, hi. Thanks so much for that. I'm from Homerton, and I know Venetia, who's our induction lead, is on the call as well. That was a really interesting presentation, just to see how much you've changed your induction process and the work you've done. And I know all of us in all trusts are struggling with the amount of inductions coming through our doors. Dilapan is something that we've used for quite a long time now for all our previous cesarean section patients. That's our first line, and we send them home and come back the next day. But for all other women, particularly those who are having outpatient induction, we give them Prostin and then they can go home and come back the next day. We're looking to explore for our primates who are incredibly unfavourable the option of giving Prostin together with Dilapan, because what we find is that their journey of induction is a prolonged period of time, increases their risk of infection, etc. And we just wondered whether those with a very unfavourable cervix who would have Dilapan together with Prostin, whether that would improve their journey of their induction and get them into labour and ARMable sooner. And I don't know whether anyone has explored that or whether that's come into play anywhere else.
Beth?
I currently don't know of any hospitals that are using them together. Sorry.
I don't think so. I've looked for the evidence. There is no evidence for Dilapan apart from using it by itself. And I think that's one of the drawbacks. I think the company should invest in a large study to use Dilapan with a second agent, because most most units will have to use a second agent, especially with the number of inductions we're doing. But I mean, I didn't want to bring that up in this conversation because this is all about diazepam. But in the real world, you would definitely, if you had an unfavorable cervix, you would definitely need to use at least 2 to 3 rounds of diazepam, two rounds of diazepam. And by the time in your second round, the woman's had 2 VEs. She's been in hospital for more than 48 hours. She is getting so disappointed, she'll be asking for a cesarean section. So I think if they want a study where you can use diazepam and something else, and I actually was not thinking of Propes or Prostin because that's another internal examination. I was thinking more of something oral. That might be the way to go, because we do know they use balloons with oral misoprostol and they work really well. So why not diazepam?
Well, oral misoprostol's been found to increase hyperstimulation in babies admitted to NICU, so I don't think that's commonly used for induction anymore.
It is used for induction. It came out in the last NICE guidance of 2019 and used 25 micrograms 2 hourly for 8 doses and repeat. And we've been using it at Queen's since January, and we don't have that problem. So, I'm sorry, but it is definitely used now. It is recommended, and it doesn't cause hyperstimulation at that dose.
Just to mention, in terms of 2 examinations for Prostin, as a potential Prostin and diazepam, it would be the same assessment. So it wouldn't be 2 assessments. It would be when you give the Prostin, you'd give the diazepam at the same time. That's what we were thinking. So it doesn't introduce additional examinations, but it's something to think about going forward. Anyway, that's all from me. Thank you.
Welcome.
Thanks, Kitty. We've got a question in the chat, Dr. Atiba, from Rebecca at Calderdale. She's just said, with a birth rate of 7,500 and up to 8 diazepam inductions a day, how long does your wait for ARM tend to be? Do you find a longer wait has an impact on dilatation?
We tend to get them in within 24 to 48 hours now. We don't have as long as we don't have the 5-day waits we used to have. And the reason we do it that we can do that is because we have that number of 8. We used to have 15 a day. With 8 a day, we can manage quite comfortably. We have 16 birthing rooms. So we have 13 midwives on shift every day when they're available. So we that's the number we can accommodate quite easily with the RAG rating. So as long as we don't go above those numbers, we can manage very well. And, I would say that many of our women, if their cervixes are not favorable with diazepam, we either put a second series of diazepam rods in, or we offer them something else. So inevitably, they will be on the labor ward within 24 to 48 hours. But I think it's about communication and education. Once the midwives know that if we don't get these women off the antenatal ward, triage is going to get blocked. If we don't get them off the postnatal ward, we can't move them from the antenatal ward to the labor ward. It's a constant walking around the unit, making sure that the women continue to move. Once they recognize that just by not taking a woman on labor ward is not it, because I'm going to end up having a problem with postnatals, they will move them. And if necessary, like I said, you just ARM them on the antenatal ward. We used to do that when I was a very young doctor. We're doing it again now. They don't like it much, and that's why they will take them. But yes, we do manage. And they don't wait longer than 48 hours anymore. We audited it. We audited it before we introduced the clinics and afterwards. And there was a distinct reduction of at least 2 days. Plus the use of outpatients. Because with the outpatient inductions, you've got a good 12 to 15 hours outside of the hospital.
Thank you. Have we got any other questions? Sorry, I'm not able to see the chat from this. It's popping through.
Yeah, we've had another question from Lauren, and she says, have you found that your Synto rates have increased?
Yes. Yes. Absolutely, yes.
Perfect. And then a question from Poppy at Birmingham Women's Hospital. When the outpatient diazepam ladies have their diazepam removed at 24 hours, do they remain an inpatient if you ARM, or do they go home?
No, we never send them home. Once they're in, they're in. We don't take any chances. Unfortunately, during the pandemic, we had to cut corners. It wasn't very good. We once they're in, they don't go home until they've had the babies. No.
And just the other point on that as well, I don't want to comment on your practice, but don't you bring your patients in earlier than 24 hours after they have
We
gone
don't.
out?
We stopped using. We stopped using 24 hours. We used to use 24 hours during the pandemic. We didn't have we had an untoward outcome, not because of the baby, because of the Dilapan, because the patient was an undiagnosed growth restricted baby. So from that time on, we bring them in 12 hours. The Dilapan is removed between 12 and 15 hours when they're on the ward, because they can't just come in and have it taken out straight away. So we give that 3-hour leeway. And once it's taken out, if they're not ARMable, we immediately put the second round rods. If we are able to ARM, then they're put on a list. That list goes to the labour ward, and whoever's a priority on that list will then be taken one at a time. We made it very clear to the labour ward coordinators they must take 1 ARM per shift. And if they didn't, they'd have to fill in a clinical incident form, because obviously if you don't have some kind of way of making sure at least one goes at a certain time, then almost certainly you will have a block. So there's a penalty for not taking at least 1 per shift. And if you think about it, if you take 3 in a shift, you've already taken 3 of the ones that you're inducing. So that sort of behavior has made it a lot easier to manage, because everybody's on the same page about what we're doing. Yeah.
Thank you. Sorry, you go.
Lauren's just asked another question, which I think is a follow-up question to when she asked if the Synto rates have increased. She then asked, has that affected your C-section rates?
Yes. Our section rate for inductions used to be about 30%. It's now about 40%. But I have a strong feeling it's nothing to do with Dilapan. It's to do with the women's perception of pregnancy and labour. You see, in the last 6 months, what has happened? We've had Ockenden. And whether we like it or not, Ockenden is going to change everything you do in your maternity unit. Our maternal request cesarean sections have gone up by 10%. Our induction rates have gone up by at least, well, they were down to 25, they've gone back up to 35. And women just say, I've had enough, I want a section. They don't even need one. They just say, I've had enough, I want a section. And we're so frightened of going against the recommendations of Ockenden right now. You know, if a woman is determined that she can't do this anymore, she's had enough, then that's what will happen. We don't do FBSs anymore because it's not recommended anymore. In most units don't do them. We are very CTG driven. So all the things we say turn on the left side, it's fine. We always catch one section. So the whole way of managing labour and pregnancy, unfortunately, has changed because of all the problems we've had with, you know, the Telford, the Morecambe Bay problems, the problems now with Nottingham and all the other places. So we have had to become ultra, you know, vigilant, because we are such a big unit. If anything were to happen to us, it would be terrible. So things have changed quite dramatically. So I wouldn't say it's the Dilapan at all, because before Ockenden, our vaginal delivery rates from our outpatient multips was almost 90%. And inpatient multips was 79%. We were getting about 60 to 70% vaginal deliveries from our inductions. So it's not the Dilapan. It's the way we manage our labours and our pregnancies. And it's been in the last 6 months.
Perfect. Thank you. And then Charles from Sheffield has got his hand up as well.
Yeah.
It is actually Charles from Barnsley now. But thank you very much for your presentation. Thank you very much for your presentation. I think that considering the use of Dilapan with misoprostol, the 25 microgram, probably the second use could be helpful. And it's something probably worth considering, particularly in a big unit as yours, madam, because I think when we have women who are sat comfortably, not contracting as you would have when they've had the prostaglandins, we tend to push them to the bottom of the list.
Yeah.
But I think the experience of being able to go home with Dilapan. You're not worried about hyperstimulation, but to combat that drawback of possible shrinking of the cervix, as some would say, I think it's worth considering using the misoprostol. And to Beth, I think beyond just having audit reports, this possibly could change the landscape of induction of labor. I think the company should be looking at actually pushing for RCTs to be done. So we have very good evidence to back up what we're doing.
Well, we're happy to do one. We don't have a problem. We're using both Dilapan and misoprostol in our unit. We've stopped using Propes and Prostin now. We do not use them unless it's very, very rare. Our primary inducing agent is Dilapan. We use oral misoprostol for the PPROMs, and they deliver quite nicely. And I would like to think that we could look at doing a study where with the very low Bishop scores, I'm talking about the 1 to 3s, Dilapan with misoprostol. We do use Foley's catheters or Cook's balloons with misoprostol. Works extremely well. So if you don't get your oar in now, we'll be back to Foley's catheters again. Yeah,
noted.
You're right. You're absolutely right. And the evidence shows a second agent or an agent has a better outcome. You reduce your time of labor by 3 hours if you use a catheter and oral misoprostol. For those of you who are not using Dilapan, I don't want to discourage you, but I think there may be a place for this. I don't have, unless I know I'm doing it as part of a trial, I'm not sure I would like to try to do that. I think you'd have to do a trial to use misoprostol and Dilapan, especially when you can use the Foley's and misoprostol for which there is evidence. But yes, a large trial using misoprostol for Bishop scores of less than, and Dilapan for Bishop scores less than 2, compared to using just Dilapan or Dilapan and something else would be a very interesting thing to do.
Thank you for that. We've got a question from Birmingham Women's again, Poppy, just asking, is it possible for you, Dr. Atigba, to share any policies, guidance, SOPs on your outpatient Dilapan pathway? It's something that they are definitely wanting to introduce at Birmingham Women's.
If I send you my guideline, you will have everything in it. So if you want to send me your details, I'm actually updating the guideline at the moment. But if you want it immediately, I'll send you what we've got and then I'll send you the update. But yes, my guideline has everything in it, the SOPs. The other thing we have is the competencies for the midwives, because I think it's important that if your midwife is being told she's running this clinic, she needs to be able to say, I've done my 5 insertions under supervision, I've completed my competencies, I'm signed off, I've got my certificate. So if anything happens, they can say, well, I'm very well trained, and you can use that as evidence. So I think if you're going to have induction of labor clinics with midwifery-led induction of labor clinics, and I'm telling you, it's revolutionized the way we work. I cannot think of any other way of managing inductions now. And certainly it's Dilapan that supported this wholly, to be honest. But if you're going to have midwives inducing women, they need to be seen to be trained up properly. You need to have proper pathways and guidelines, and you need to be able to audit what you do. And it will make a big difference. We do not have delays anymore. We really don't. So if you do want my guideline, just send me your email. I'm on an NHS email, or you can send it to Charlotte, and I have no problems forwarding it to you.
That's amazing.
Yeah, there's a couple of email addresses that have come into the chat, so I'll ensure that all of these are passed over as well if you've popped them in there.
Alternatively, what I can do, Charlotte, is I'll send you what I've got and you can send it to them if they want. But I'm very happy to answer email requests. It's fine. It's not a problem.
Perfect. Brilliant. Thank you.
Is there any other questions before we close the webinar? Has anyone got any last minute thoughts? I will take that as a no. Thank you, everybody, for attending. Anybody that's asked for specific things to be emailed to them, we will get that sorted. This recording will probably be ready in about a week or so, give or take. So we'll get that sent out, and the slides if you are wanting them. And if you do have any further questions, you should all have our email addresses already from the invitations to the webinar. So if you do have any further questions following on from this, or anything that you want to discuss with us, then please do just get in touch, and we'll be more than happy to send you, data that you're requesting and things like that. So please do ask away. And thank you for joining us today. And thank you, Dr. Atiba, for that talk. It's been really interesting to listen to. So thank you.
Thank you very much. It's been a pleasure. This is definitely one of my passions. So it's been very enjoyable for me too. Thank you.